Thanks, Jenny. Hey, thanks for joining us this morning for the Grand Rounds. Our speaker today is Dr. Miriam Behar, Mimi as we know her. She is a caring and thoughtful pediatrician in our practice in pediatrics. She is board certified. She is associate professor of pediatrics in our department at the Wayne State University. Mimi did her MD from Johns Hopkins, and she did residency in pediatrics from the same place. And she has been practicing pediatrics ever since, but she has also gone around the country a bit, and she has worked at various places, including Kentucky, Missouri, Oklahoma, Texas, and most importantly in Michigan. She does a few things in her spare time, but the most exciting thing to me is she plays violin. And if you see someone like her next time you are watching Detroit Medical Orchestra, it's not someone like her, it's her. She actually is a member of that orchestra. Something to keep in mind, yeah. So, yeah, I could go on and on, but looks like we have a very interesting talk coming up. And the title of this talk is Shoulder to Shoulder Global, a sustainable model for global health practice. And maybe.
Thanks for the introduction, Tej. I became a faculty member at University of Kentucky in 2009. I moved there with my husband, and shortly after I got there, got to know one of my colleagues, Dr. Tom Young, who is sort of the founder and leader of Shoulder to Shoulder at Kentucky, and started these medical brigades. So I was intrigued. My daughter was going to be a senior in college the following year, and was going to be applying to med school, and thought this would be an amazing experience to go on actually with her together. So I attended my first brigade in 2010 in Ecuador. And I've been going ever since, pretty much every year, except for the 2 years, during the pandemic when people didn't go. So the brigade that I went on last month, with the team from Wayne, was my 13th brigade. So it's really become part of my life, and something I'm really passionate about. Why is it not advancing now? Jen, what do I do? My slide didn't advance.
What you could do is maybe get out of presenter mode and try to get back into presenter mode.
Well, I'm hitting escape and it's not.
Oh, it might have frozen.
Yeah. Okay, what do I do? What? Can you take over? Or?
It's okay. You're among friends. Let's see.
Yeah. Yeah, it was working before. Maybe if I turn off my video.
Yeah, that might help actually.
So I did that. It's still not. That's funny because I can still see people, whereas I wasn't seeing people before. I don't know what to do.
Let's see.
Should I stop sharing and try again?
I would try
start
to.
all over again.
Yeah.
Don't worry, it happens. So just take it easy and just restart all over again.
Okay. All right. Stopping the share. I'm going to go back to share screen. Let's try this again. Nope. It's still not wanting to advance. Yeah.
Can you try to click on the slides on the left and see if that works?
Yeah, I can do that.
See if that.
Yeah. All right. So should I?
If you want to do it like that, that should be fine.
Okay. I'll just do that. Sorry, guys. I don't know what happened there. All right. So my learning objectives are to discuss some requirements for providing medical care in another country, and to understand some of what you need to be able to do that. and then also to learn about some of the common pediatric problems seen in Santo Domingo in Ecuador, which is where we go. And I have no financial disclosures. And again, technical difficulty. My intention was to show you a nice 4-minute video from the Shoulder to Shoulder website about the brigades. Jen and I we practiced yesterday and tried to make it work, and I couldn't, but she'll put the link in the chat. And it's only 4 minutes. It's a nice video, but I can do without it. But I'll tell you a little bit about the history of Shoulder to Shoulder. So this colleague that I mentioned, Dr. Young, he had a passion for global health and really wanted to bring this to University of Kentucky. And actually he started a global health track for categorical pediatric and med-peds residents. And there's also one there for family practice. And he, in 2002, for the first time, so over 20 years ago, he went down to, he had identified this area in Santo Domingo, Ecuador, that was a very poor area and had a need for medical care. And he came down with a group of residents. It was a pretty small group. They did some community clinics, did that for a few years, and then realized pretty quickly that this wasn't a really sustainable way to do global health, to go in for a week and see patients and then not have any sort of follow-up or anything like that. So he raised money, I think put in a lot of his own money. And 5 years later, in 2007, opened a clinic there, basically bought a building, leased the land from the church, and opened a clinic, and started a foundation basically to support the clinic. And that year in 2007 was the first year that he brought down an interprofessional group, which included, among others, nursing and pharmacy and physical therapy. And now there are 4 brigades a year that go from Kentucky in March, May, June, and August. But the clinic that he started is there year round, and basically services this community. I guess oh, now it's advancing. I'm gonna stay in this mode though, because I'm afraid if I change it, it's gonna jinx myself. So yeah. I'm just gonna keep going.
Yeah, that's fine.
Yeah. Okay. So this is a map of Ecuador that shows you where this area is. Quito is it's about 3.5 hours east of there. We go by bus, but also by car over this beautiful winding mountain road. Quito is very high elevation, like 9,000 feet, and Santo Domingo is lower, I think closer to like 3,000. And this is the province of Santo Domingo de los Sachilas. I'll tell you more about the Sachilas later. And this is another cute map. This is actually from the front page of the provider handbook that we use. And you can see, can you all see my pointer? You can see Santo Domingo here. That's the town within the province. And then Quito is just due east of there. And then this is the Pacific Ocean, because Ecuador is on the coast. So this is the clinic. This is the staff standing on the grounds of the clinic, and kind of back here, there's sort of open air windows. This is Centro Médico Hombro a Hombro. Hombro a Hombro means shoulder to shoulder in Spanish. This is the clinic that was established in 2007 that my colleague Tom Young, arranged to purchase, and then this staff was hired. It is supported and run by the Hombro a Hombro Foundation. I'm a voluntary member of the board of directors, and the board is made up of both Ecuadorians and Americans. It's located in a cooperativa. It's called Carlos Luis Barneo. It's about 20 minutes from the center of the town of Santo Domingo. Santo Domingo's population is about 400,000 plus or minus. It's a very rapidly growing area in Ecuador. It's kind of at a crossroads of several highways. And it's accessible. The clinic is accessible by taxi and private vehicle, and there's some bus stops a few blocks away from the clinic. And it serves several, they're called barrios or neighborhoods, including Carlos Luis Borneo, where the clinic is, A couple of others are called, one is called Plan de Vivienda and also Luz del Dia. In these front grounds where you see the clinic staff standing, that serves as a general waiting area. The clinic has treatment rooms. It has a dental room with a dental chair and lights. There's a lab and pharmacy area. It's got electricity, running water, a septic tank for sanitation disposal. They dispense some basic medications to patients, and they have just very basic equipment: blood pressure cuff, stethoscopes, EKG machine, nebulizer, centrifuge to do hematocrits, and a microscope. They don't have a full lab at this point, but that's going to be coming. There's also an autoclave for dental and surgical tools and specula. And before opening this clinic, the Kentucky partnered with some key members in the community. One of them is a cardiologist from Santo Domingo, Dr. Leonardo Oviedo. He was a founding member also of the clinic, and he still practices part-time, and he's also on the board. The foundation, the clinic leases the land. It's like a 20-year free lease, and I think it's from the church. And then the clinic staff, there's someone there that provides all the maintenance, and I think actually lives on the grounds. And some really exciting news is that the foundation just received a USAID grant for over $400,000 to expand the clinic. And that's then it'll include like a full lab and like an indoor space to do physical therapy and rehab. Right now, physical therapy is done in kind of an open air pavilion that's on the grounds. And they're going to open a women's wellness center. They're still working on kind of final approvals to start all this construction. They're hoping to break ground pretty soon, and they're planning a groundbreaking ceremony actually next month when the August brigade goes down. So very exciting. I wanted to just introduce some of the folks here. So the gentleman that's third from the right, he's the physician in the clinic, Dr. Christian Carrion. We call him Dr. Christian. He's fantastic. He's a general practitioner trained in Ecuador, lives in Santo Domingo. He's been with the clinic really since the beginning, and we work with him, very closely when we see patients in the clinic. Lady next to him, Ligia, she's a registered nurse. Couple of people over, this is Maricela. She's the business manager for the clinic, and she's actually about to take over as the president of the board. I'll explain that in a minute. And then this lady over here, second from the left, this is Mercedes. She's a social worker, and she's really one of the main people who reaches out to people in the community, keeps tabs, especially on chronic patients, and helps arrange when the brigades come down, which patients they're going to arrange to come and see us. There's one other person that's not pictured who's important. It's Barbara. She's a dentist. She works half days. She's also there on site when we do our brigades. And as I'll mention later, she's one of the main people that we refer patients to. She does a lot of work there. And then this gentleman, the one on the far right, last but not least, this is Pablo Boada. So he's the current president of the foundation board. He's been with Shoulder to Shoulder since I've been doing the brigades. He's Ecuadorian. He lives in Quito, and he's sort of our main point person for arranging all the logistics for the brigades from Quito. He's an attorney by training. He's the main contact with like the Ministry of Health to ensure that everything that we do has their approval. All the professionals that come on the brigades, we submit our licenses every year. Anyone who's coming as a faculty person or attending, and we get approval before coming. He oversees logistics. He figures out which sites we're going to go to at each brigade, depending on, he works with community leaders basically to figure out, where the greatest needs are. Yeah, so, so we have, and there's a point person also in Kentucky, University of Kentucky, that works very closely with him and kind of arranges logistics for the brigades from our end. What's amazing is the trip that I just went on, that we went to 5 different sites on 5 different days, and I had never been to any of those sites because there had just been a brigade the previous month, and so he basically worked to find other sites that we could go to that had a need. So all of the places that I went to this last month, I had never been to before, which was really cool. A lot of the places I've been to, year after year, and 3 of those sites actually were areas where this indigenous group, the Sachila, live. I'll describe a little bit more about that later. So we'll just keep going. This is just a nice pano that I took a number of years ago that kind of shows the exterior of the clinic. So in 2017, when I went with the Kentucky group, there was a design professor who came down, and she designed this this mural, and actually it was painted by people on the brigade that year, and it's held up really well. We used to paint it almost yearly with this really cheap paint, water-based paint, but she used a much better paint, and so it looks pretty good. I mean, the design is still there. It's a little bit faded, but kind of gives you an idea too of the kind of the surroundings. So it's on basically kind of unpaved roads. It's very lush. There's really nice gardens inside, but that's kind of what the exterior looks like. So I'll tell you a little more about the brigades. This is where we stay when we're working in Santo Domingo. It's called Casa Santa Rosa. It's gorgeous. It used to be a convent. It's still owned by the church. We stay there for 6 nights. Usually we do the 5 days of clinics. And so it's our home for almost a week. It's run as a guest house. I think the church still owns it, but it's run as a guest house by a family that's been there for years. They provide our meals. So we have breakfast and dinner there. Lunch is they actually pay some ladies in the community to cook for us during the brigades. So we get home cooked meals 3 times a day. They're safe. They use everything's purified, and so the food is safe to eat in the casa and when we go on our brigades. And it's beautiful. I mean, the ferns, they're beautiful gardens. There's a beautiful courtyard with a fountain. There are always flowers. It's a really very basic accommodations, but a very pleasant place to stay. Not all the rooms have hot water, but it's pretty hot down there, so you don't really mind taking a cold shower at the end of the day. This walkway here, this is in front of right in front of the open air dining room where we have our meals. And that's just a goofy. It's owned by the church. A lot of the rooms have this picture in them. This was actually outside of one of the rooms that I stayed in a number of years ago. And then I pulled this from the Shoulder to Shoulder website just to give you a sense of the kind of the scope and how many, how much work has been done there over the last 15 years, just in terms of the numbers. So, 40,000 plus patients, 1,300 participants, 30 residents, and this is over a 9-year period. Interestingly, it doesn't mention medical students here. At Kentucky, the main learners that I worked with when I did the brigades at Kentucky were residents. Students did come on some of the trips, but just their schedules didn't always coincide with when the brigades were. I did go on a trip a few years ago where we had a couple of M3s that saw patients, and then also been on some trips with like 1st and 2nd year students. There were a few students from Kentucky on this trip I took also, but just to kind of give you an idea of the numbers in terms of how many patients are seen and how many participate. I'll mention that all the learners that come on the trip are required to take a pre-professional course, which is run by faculty at UK. It was not from the very beginning when I started, but at least over the last 6 or 7 years, there's a faculty in nursing and in pharmacy that basically develop the course and run it. The students take it for credit. Our students had access to it, the students that I took down, but they weren't required, but I think a number of them looked at the materials. The students that I took down, I went with 5 of our M4s. 4 of them actually stayed after the brigade for an elective in Quito for 3 weeks that was arranged by Mark Zervos, Dr. Zervos. He's an ID doctor from Henry Ford, who's just stepping down as Vice Dean for Global Health Affairs in the medical school, but he'll still remain involved in global health. And it's also important when you're working with other universities to have it be both ways. So Dr. Zervos actually did arrange earlier in the year for some medical students from University of San Francisco, Quito, USFQ, to do an elective here at Wayne. And he told me that was very successful. So I'll keep going. There's mostly pictures. This is the first brigade, the very first brigade I went to in 2010. I just wanted to give you kind of a sense of numbers. There's actually Pablo Boada, who's our board president on the left. I'm on the right here. I'm all the way on the left. This is my daughter here. So smaller group. This is a site that we don't actually go to anymore. And then this is the group this year. So the prior group was close to 40 people. This is actually closer to 60 people. So the numbers of folks that go on the brigades has really grown over the years. There's Dr. Tom Young, kind of our leader, and our students are in there. I'm actually not in that picture because I was doing something else when they took that picture, but most everyone is there. And then this is the faculty that came down from Wayne with me. This is Dr. Christine Malinowski. She's in the College of Nursing at Wayne. She's actually a nurse practitioner. So there were several other nursing faculty from Kentucky. So she actually was a provider and saw patients. She had a nurse practitioner student. She took down 6 students with her from Wayne College of Nursing. This is Dr. Martha Schiller. She's a physical therapist at Wayne faculty. She had a couple of PT students with her that actually did they did an elective the month before the brigade in Quito. So they also went down for credit and then came on the brigade at the end of their trip. That's me. That's Dr. Tom Young, who's our founder and the leader of the Kentucky Brigades. Just wanted to give you an idea of sort of the core composition of the interdisciplinary team that goes down there. So, and all of these disciplines come down with faculty or attendings and students. So medicine, nursing, pharmacy, physical therapy, both adult and pediatric. On this trip, we had Dr. Schiller, who's a adult PT, and then she actually recruited a pediatric PT from University of Florida. So we had more than 2 universities represented, who also brought a couple of students with her. So we had both adult and pediatric physical therapy. And then probably one of the most important groups that we collaborate with are the interpreters. These are usually Ecuadorian medical students. All of the students that we had on our trip last month were 5th years. So they are sort of just, in Ecuador, medical school you start right after high school. So it's a 6-year program. And they were just about to go into their clinical years. So they hadn't had a lot of clinical experience yet. But they're amazing. I mean, I've been working with these medical students for many years. They're from various universities. All of the ones on this trip were from USFQ or University of San Francisco, Quito. We've worked with several other universities before. Some of the students come back year after year, so I've gotten to know a number of them over the years, and some of them came as students and then came back years later as providers. So in addition to the doctors that come from the States, we also have physicians from Ecuador that come and work with us. So, and as I said before, all of the professions consists of attendings and students. Not all the attendings are faculty. Some are just alumni who came back, or other faculty, other attendings that were interested in going on the trips. So I've been on the trips many years with physicians in private practice who find out about it and want to come. And a lot of folks that come as students will come years later then as attendings, which is also really cool. So there's a lot of continuity. And we've also had teams from like entire teams of folks from Ecuadorian universities. Not this trip, but a couple of years ago when I came, there was a whole group from Guayaquil that came from a university there with both medical students and attendings and nurses. And then we've also worked extensively with physical therapy from universities in Quito. There are several physical therapy attendings that have come down with students and worked with us. So it really is a collaboration between Ecuadorian and American physicians. There are other professions that come down occasionally. We've had psychology. We've actually had groups of psychologists from Quito come down and provide mental health services. In the past, couple of years ago, when I was already living here, but I went, there was an engineering team from UK that worked on a water purifying system that could potentially be used by some of the communities in the future. I'm just looking at my notes. We hold 5 days of clinics, usually from a Sunday through a Thursday, at different community sites. Some of the sites are at schools or community centers and actually churches within the city of Santo Domingo. And some of the sites that we go to are more remote in one of the Sachula communities, and I'll talk about them in a little bit. We always spend 1 day at Centro Médico, working in the clinic there, and that's luxurious because then we actually have exam rooms. It's indoors, and then we also have the availability of Dr. Christian and Barbara, the dentist. They don't see patients, but they're there basically to consult with us. They know a lot of the families, and so can sometimes help with kind of formulating a plan and arranging for follow-ups. And I wanted to emphasize one really important thing. We don't treat anything chronic, both in adults and pediatrics. So I see really our role on these brigades when we go into the communities is basically to see kids for checkups, maybe treat some minor problems, but also triage, find patients a medical home that need a medical home. We basically do a lot of triaging to the clinic. And refer patients there for a follow-up, especially if there's anything chronic going on. So we're not there to treat chronic conditions, which I think is a really important point for a medical brigade. So I'll keep going here. There is a medical provider handbook. That's the link for it. Jen maybe can put that in the chat as well if you're interested. It contains some information in the introduction just about cultural aspects of care in Ecuador and a history of shoulder to shoulder. This is the most recent one. It's from 2019. I don't think it's been updated since then. And then it kind of goes through some of the common conditions that you see and recommended treatments. So I use it as a resource. I usually print out a copy and have it with me, just to refer to during the brigades, especially for dosages and things like that. So what are some of the commonly encountered problems, or this is specifically pediatric problems? A lot of what we do is what they call control, which is just child visits, and a lot of worried a lot of reassurance, reassuring parents that that their kids are healthy, and then listening to their concerns and trying to address anything that we feel that we have the ability to, and then if not, to refer them to the clinic. We do see some constipation. We try to mostly handle that with dietary recommendations, fiber and water. The diet there is very high in refined carbs, a lot of rice and potatoes, not a lot of protein. I try really hard to convince people to use quinoa instead of rice. Quinoa is actually cheap down there and it's plentiful. People use it in soups. They don't usually use it as a starch, but it has a lot more nutritional benefit than rice does. So I tell people to do that, whether they do or not, I'm not sure. And we rely on our interpreters a lot because they know they live in Ecuador, they know what's available. So, I'll often ask them, if I'm going to make a recommendation for a patient to eat something, I ask, is this affordable and is it plentiful? We recommend things like beans and, things that are higher in protein. We see some minor infections, not a lot. I did treat a few kids last month, maybe a couple for otitis media and a couple for community-acquired pneumonia. Not terribly sick. Maybe I think one child I saw was actually febrile at the time. Lots of minor skin conditions, so insect bites. It's a hot tropical climate, tons of mosquitoes. Some atopic dermatitis, some impetigo occasionally. We've got some topical antibiotic creams and just like 1% hydrocortisone. There's a lot of pityriasis alba, which is this kind of these light patches that kids get, especially on their faces. It's just kind of a variant of atopic dermatitis. I don't usually do much about that, just reassure them and tell them to moisturize. There's some anemia. I don't think there's as much anemia now as when I started going. I don't know if it's because nutrition has improved. We do prescribe a lot of vitamins with iron for kids. And so a lot of the kids that I think have come back to the brigades year after year, I think their anemia has improved, but we have iron to treat it and then we always refer, if we treat a child that's anemic, we always refer them back to the clinic for follow-up. Probably the most common thing that we see is dental caries. So we make a lot of referrals to the dentist. And then parasitosis is kind of endemic there. Just kind of a list of some of the common parasites, not always symptomatic, but sometimes it can be. And we often, we'll ask patients if they see worms, or parents if they see worms in their kid's stool. I've had people bring in pictures of various things that they found in their kid's stool. So our policy is to treat. If patients haven't had it's albendazole, if they haven't had it for 3 to 6 months, we prescribe it. So and the nice thing is if they come back to the brigades at least once a year, most the kids do get treated at least once a year. They get it from other sources too, but we do. That's probably the most common thing that we prescribe. Everything that we prescribe is easily accessible. In Ecuador, if we run out of things, we purchase drugs down there. We do bring some down with us, but we try not to bring anything down that's not affordable there or that can't be gotten there. I just took this. I always take a photo of they have a paper formulary that they'll kind of write in if things change, but that's just kind of an example. So you can see a bunch of antibiotics, some just basic pain relievers. If you notice, there's no like antihypertensives or anything like that, just some dermatologic stuff. I noticed there was Miralax on there. I never prescribe Miralax. I mean, it's hard to get down there and it's not affordable. So I'm not sure. And I've never seen it on the formulary before. I didn't prescribe it this time. So I'm not sure why it was on there. That was a little unusual. We give, we generally, all the kids 5 and under get hematocrits. And so, if they're anemic, we'll treat them. And then we also, girls that are menstruating, so usually 12 and up, and then women also get hematocrits done. We have lots of prenatal vitamins. So for the adolescent girls, we usually just give them those. And we try to give at least a 3 to 6 month supply, just depending on how much we have down. Again, the vitamins are donated, so we usually have lots and lots of them. And then just some artificial tears, some prednisone. I don't think I've ever prescribed prednisone there. I suppose probably the folks that are seeing adults will, but that's just kind of an overview of the formulary. And then I just mentioned the most frequently prescribed medications that I would prescribe. So, a lot of the kids they'll have their visit, and, if everything is good, we'll give them vitamins, and then we'll usually give them albendazole if they haven't had it. The parents usually can recall if they've had it within the past few months. And then again, occasionally prescribe antibiotics, but not very often. And then the topicals. Yeah, so I wanted just to talk about the interprofessional aspects of going on the brigades. I think that's one of the most valuable learning experiences for the students, is that they're working side by side with these different professions and really collaborating. We're usually practicing in the same physical location with nursing and pharmacy and physical therapy, which is not typical, in regular practice here. So there's a lot of back and forth, running back and forth, from to the pharmacy, back to nursing, if we need them to do something else, and running them over to the physical therapist if we need a consult. The PTs do have their own patients usually lined up to see them that have been kind of identified ahead of time. But if we're practicing in the same place as them, we can bring patients over if they need some physical therapy services. And we really try to have the students, especially the nursing students, kind of rotate through and shadow with the other professions so they can really get an idea of what the other professions do. And I'll mention one really unique experience that I got to participate in actually for the first time last month. Normally on the day that we're at the clinic at Santo Domingo, they arrange for at least a couple of like complex patients to come in to have an interprofessional consultation. There was just one patient this time. It was a pediatric patient, and so I was asked to kind of lead that session. So basically, where there's a nice room at the clinic that has a bunch of chairs and a sofa. And they identified ahead of time a little girl, a 6-year-old with microcephaly and severe psychomotor delay. She had epilepsy, failure to thrive. She had a feeding tube. The team consisted of myself and then one of our M4s, who actually fortunately was, he's an MD PhD student from Wayne, and his research had been in epilepsy. So he actually had some nice pediatric neurology background. There was a dietitian actually from Ecuador who had worked with the clinic who was there. We had our 3 pharmacy students, a couple of nursing students. The clinic social worker, Mercedes, she is one of the ones that identified this patient. She took copious notes the whole time to make sure that the plan that we came up with was followed up on and carried out. We had the pediatric PT from University of Florida, and then Dr. Christian, the clinic physician, he actually was in and he presented the patient, and then also participated in the assessment. So this girl had a gastrostomy tube, which had been placed in Quito. She was significantly underweight. The mom basically was pureeing table foods and putting it through her tube. She was just blending things. She couldn't afford anything like Pediasure or anything like that. And the girl was on valproic acid, which had been working initially for her seizures, but lately she'd been having more breakthroughs. I mean, she's fairly incapacitated. And the problem with the valproic acid is it's also very hard to get in Ecuador. And the mom was close to running out. She didn't have a lot of it left. So we went through this kind of system assessment. I kind of led it, did her exam in front of everyone. And then we kind of addressed each of the issues and got feedback from all of the professions. So the dietitian made some recommendations for changing up her feedings to try to increase her calories with affordable things that the mom could get. The pharmacy students had their references with them. We talked about her epilepsy medication. This is really pushing my boundaries because I'm not a neurologist. But Christian does treat seizure patients. Their pediatric neurology in Santo Domingo doesn't really exist. So he looked up, medications and prices in terms of what was available and affordable. And then we came up with basically a plan with the pharmacy students. We came up with a plan to wean her off her valproic acid and start her on lamotrigine. And then the plan was to have her follow up with Dr. Christian in 2 weeks. And Mercedes wrote all this down and, was going to make sure that it was going to happen. So it was a pretty cool experience, and hopefully she'll get her follow up, and hopefully her seizures will get better. All right, now I'm going to show some pictures. Trying to rush through here. This is just kind of a typical medical team setup. So this was my team one of the days that we went to one of the Sachula communities. So Fran was our interpreter. This is Miles Hardiman. He's a 4th year. He couldn't be here today because he was starting his ER rotation. And this is a rising M3 medical student from UK. So the two of them really kind of took turns. One of them scribed. We do have an EHR, so the students did a lot of scribing, and they took turns interviewing and scribing basically. So they pretty much ran the visit while I was there. We all did the exam together. The kind of this rickety table. We actually bring down some of our own exam tables. So that's what our team looked like, and you can see it's a dirt floor. It's very, very, very rural. Lots of lush stuff outside. So lots of livestock walking around. It's another team from a number of years ago. It's one of my former residents, the gal with the glasses. She's an intensivist now, but she was on our global health track there. That's the interpreter, probably someone shadowing here, and then a parent and child. So, and I threw this picture in just to show what the close quarters are like sometimes in some of these clinic sites that we go to. I mean, we're in like a sort of a community building, sometimes usually open air, but you can see, I mean, there's a team here and a team here. It's chaotic, it's hectic, it's noisy. You're trying to listen with the interpreter and listen to what the family is saying, and the parents are trying to keep track of all these kids running around. So it can be pretty challenging conditions to try to, provide good care. This is a nursing team. This is also from a number of years ago. I didn't take a lot of pictures this time because I didn't know I was going to be doing this, but they've got their centrifuge set up to do hematocrits, their urine dipsticks. They're, I think, waiting for patients. Patients have to go through registration first, which can take a while. This is this year. This is our pharmacy team. This is Candace was a pharmacy student at UK. She was a practicing pharmacist for a number of years. She's now doing some cool nonprofit work, but she was our one pharmacy faculty, basically. These are the pharmacy students from UK. Wayne did not have a pharmacy team this year. We're hoping that that'll be an addition the next time we do this. And then this lovely lady she's a lawyer from Lexington, and she came as a community volunteer. We became friends. She did most of the fluoride treatments on the kids. So all the kids, after they go through nursing and medicine and they go to the pharmacy, they get their albendazole, and then they get a fluoride treatment, fluoride varnish, which I do some of those too. And then this is this gal doing a fluoride treatment after this little girl got her albendazole. I asked her if I could use her picture, and she said that was fine. This was from a number of years ago when we actually had a dental team. These guys are both dental students from UK, and they're doing education with this little girl about toothbrushing. Kind of cool. And then I just have a bunch of pictures just about the prep, especially for physical therapy, for bringing equipment down. So, AFO splints. One day, usually when the brigade is down there, there's a pediatric rehab facility in Santo Domingo. And so the pediatric team usually goes there for one day, and they do bring down a bunch of equipment. You can see a walker here. These were probably designated for some patients that the clinic identified. So there is a lot of equipment that gets taken down. Can be challenging sometimes just getting it through the airline. And then just more, they do bring down shoes. People run around in flip-flops and have a lot of foot problems. It's not just giving out free shoes. I mean, we do it in the context of a physical therapy consult, but they do get shoe donations and bring them down so that some people can be fitted with shoes that'll help them with their foot problems. Just kind of showing the hard work, packing, all the suitcases. So physical therapy and pharmacy have to do a lot of work. Prep work the night before to get their bags packed and make sure they have all their supplies. We just have to bring our equipment with us, stethoscopes and stuff, more shoes. This is just what a clinic set up in a church looked like. We didn't go here this year, but ladies in the community, the community sets up for us. And so they'll often hang sheets to kind of do these makeshift exam rooms. And then they're actually, if you go further back, there are actually pews that we sit and do our clinics on, but just to kind of show you what another clinic site looks like. This is my team of medical students, the 5 of them. This is a beautiful tourist stop that we go to on the very last day. It's right at the equator. It's a volcanic crater actually with a town inside of it. So it's a great photo op, but that's me and my group. Uh-oh. No, it's not wanting to advance. These are the three interpreters that I worked with the most. The guy, Sebastian, I've worked with him several times, so I knew him from previous brigades, which is really cool. And then I'll talk really briefly about the Sachila. So this is the endemic group that lives just in this province in Santo Domingo de los Sachilas. There are lots of endemic groups. I don't mean endemic, indigenous is what I mean to say. There are lots of indigenous groups in Ecuador, but this particular group only lives in this one area. And they're called Los Colorados because they have several hundred-year-old practice of dyeing their hair with achiote, which is a natural plant substance that's bright red, and it was felt to protect from certain diseases like measles and malaria. So they now do it more just as a kind of a traditional ritual. This is one of the Sachila sites that we went to on this particular, on the trip that I was on. It's a school. So we were basically set up in classrooms. So there's like a big courtyard in between, but that's the pharmacy actually was in this building right here, kind of open air. Just lots of livestock. And I wanted to show you so cacao grows wild everywhere. Ecuador makes a lot of chocolate, and a lot of the Sachila work in agriculture. Interestingly, this was from a number of years ago at this one site that I've been to multiple times. There's a lot of intermarriage among the Sachila. I'm just noticing that people are frozen. Can people still hear me?
Yeah.
Okay, good. It just seems like nobody was moving. Never mind. So this one community, so a lot of intermarriage. A lot of the families have the same last name or same two last names, because you always have the mother's name and the father's name. Actually, the father's name first and then the mother's name. But this is a family with several children with albinism that I've seen several times over the years. This mother has had multiple kids that I've seen over the years. So just kind of interesting, that there are some genetic disorders because of intermarriage. And then we usually get a cultural presentation at the end of one of our Sachila brigades. So this is a cleansing ritual from, again, one of my former residents. She's getting kind of wiped down with some branches, and it's a cleansing ritual that they do. And then he's holding the achiote that's crushed up, if you notice, his hair is dyed red. And then one of the guys volunteered to have his hair dyed. This again was a few years ago. And then they do some dancing. They play some really nice kind of rhythmic music and have dancing. We all participate in that. The little girls here are wearing these beautiful, colorful skirts that are traditional, and the guys wear these kind of black and white striped skirts. This is just a musical instrument. It actually was sitting in one of the exam rooms that I was practicing in a few years ago, and then they used it in the cultural presentation. I just thought it was kind of cool. It's a xylophone. And then at the very end of the trip, we have our 5 days of clinics. We then usually get bused to a town called Mindo, which is kind of an eco resort. It's very Ecuadorian, though. It's not a place that American tourists go to very often. And the kids do lots of different activities. I've actually done some of them. There's zip lining and waterfall rappelling and tubing. Done all of those. Do not need to do them again. But I go on a hike every year. Usually there's a beautiful hike to some waterfalls. So this is me a few years ago on one of those hikes. So that's it about the brigades. I wanted to just share a little bit our students' experiences on the brigades. I asked my 5 students to just send me a quote. I got them from 3 of them, so I'll kind of just You can kind of read it. It was described as a true cultural immersion. I felt that I became part of Ecuadorian culture and society. And as a result, I feel that I'll be a more culturally sensitive physician, particularly with my future Ecuadorian patients. And then for this person, the brigade was an amazing experience. I had the opportunity to work with many different professions, including nursing, pharmacy, PT, to really help make a valuable difference in the lives of our patients. It really opened my eyes to the positive impact we can make as physicians on a more global scale by helping people from all parts of the world, and got me really excited for my future career working in medicine. And then again, another amazing experience. We were directly involved in patient care, provided us with an incredible learning opportunity, and the experiences I had learning about global health and the friendships that I made with the USFQ students were the best part of the trip. And then is Nimra, are you on?
I'm here.
You're here. Okay. Nimra, Hassan agreed to just share briefly some data that she collected. She's one of our M4s. She's very proactive and conducted a survey. So she also instituted, we'd never done this before. We had a huge WhatsApp group, basically, which was great because we could all talk with each other, text with each other constantly. And then so she had this survey, in a link, and the students did it before and after. So I'm going to just let her share her data.
Yep.
Take it away. Thank you, Nimra.
Behar. So hi, my name is Nimra. I'm a fourth year med student that was blessed enough to go on this trip for a month. It was super fun. You made a lot of friends. I'm actually meeting a couple of Ecuadorian med students this weekend, so in Chicago. So very exciting. But what I wanted to share with you guys is kind of like my intent with this is understanding the impact of global health on our medical education, and how I think it's a necessity to have a full comprehensive medical education. And so I sent out a pre-survey and a post-survey, and these are just a couple of the results. We're still doing statistical analysis and figuring out all the p-values and whatnot, but this is just a base understanding. As you can see, so the first question we asked was, what is your understanding of the Ecuador's health system? And if you see in the pre-survey, it's pretty skewed towards the left, or it's positively skewed. So most people said slight to no knowledge. And then something that you notice after is in the post survey is, what is your understanding of the Ecuador's health system? It's skewed to the right. So it's negatively skewed, which is great because no one after the brigade had marked slight or no knowledge of the Ecuadorian health system. And I would argue a lot of South American health systems are quite similar. It's fee for service. So it was really cool to be able to see that transition happen. Next slide, please, Dr. Behar.
Oh.
All right. So another one of the things that really made me happy is that the Global Health Brigade positively impact you to include global health in your career. 92.3% said yes. So 7.3% said maybe. That is an overwhelmingly positive response for me. I'm super pumped that people are getting interested in global health, especially post-COVID. I feel as a medical student, a lot of our global health efforts were, our involvements and our opportunities to kind of get involved were minimized. And so this was great to hear. And it's something that I really hope that people carry with them forward, and 100% rated this as an outstanding experience. Next slide, please. Yeah, so I'll be real quick. I'm not going to talk all in depth, but one of the questions that I asked was, what experiences did you find beneficial for your degree? And the overwhelming theme that was coming from all of the responses was the gaining confidence in their abilities, even if with the language barrier, addressing problems that come up when that you can't necessarily prepare for. So like working in a resource scarce environment. So figuring out where to find examination tables, sometimes using massage tables as examination tables, just the little things that we take for granted here in our clinics. These are things that people learn moving forward. Another big theme was actually, Dr. Behar, would you mind going back one slide? I think we skipped one.
Oh, I apologize.
There you go. Yeah, I was confused for a second. So the other question I asked was, did the Global Health Brigade meet your expectations? So this is where we talk about like people learning kind of how to navigate their medical profession within a limited scarce environment, and how it shouldn't be incorporated into our studies, which I'm really excited to hear about again. And then the next slide. So yeah, there you go. So what experiences did you find beneficial for your degree? This one had an overwhelmingly similar theme, and Dr. Behar mentioned this earlier, was everyone was mentioning how their interprofessional skills have grown quite a lot in terms of just being able to speak between pharmacy and medicine and nursing. And I definitely saw that. Triaging the medicines that were more important, you know, we were working within a limited supply. So pharmacy saying, oh, we're running out of this or that, and us being able to kind of medically disperse it for those with the most need versus with the least need, that kind of thing. It was really cool to see how well we gelled together and be able to talk to nursing. And I think more so it is more so a necessity in a clinic like the one that we made in Ecuador. So those were my findings in the survey. It was a phenomenal experience. I hope to go again one day, and thank you so much.
Great. Thanks, Nimra. That was wonderful. Yeah, so we're done. I really stretched it out to an hour. I wasn't intending to, but I'll just go through my key takeaways, and then Laura, I'll answer your questions. So basically my key takeaways, that medical brigades just done in isolation are not really sustainable. So I think a model like this, really makes sense. And it's very important to partner. If you're coming in from the US to other countries, you need to partner with the local community that you're serving to make sure that you're meeting their needs and that they're active participants, not just coming in and doing things for people. So I think that this model, this shoulder-to-shoulder model with a clinic, a year-round clinic that provides continuous care to the community is kind of unique and a sustainable way to practice global health. I think we demonstrated that the students who went on the brigade found it to be a unique and valuable experience. And I think there's opportunity for Wayne State to participate in this endeavor going forward. That's my hope. So, all right. Laura, what's up?
Thanks, Mimi, for a fascinating talk. I have a question for you, but before that, I want to thank Nimra as well for presenting the data. And Nimra, you may want to increase the number of people in the survey and see if you can get a comparison group from the US, because that would be fascinating. You showed us what it is like in Ecuador, and I don't want to make any comments on what the likely results from the US are going to be like. But that could be a great study and might even get published, something to think about. But thanks for presenting your data. The question I have, Mimi, is you mentioned that quite a few kids have anemia. Is it because of nutritional deficiency or because of recurrent infections, or both?
I think it's probably nutritional. Honestly, I don't think these kids get lots of infections. That's never been my impression. I just sort of over the years that I've done it and the kids that I've seen, they're actually pretty darn healthy. I mean, they're small. I didn't mention this, but I mean, Ecuadorians are small. So you see a lot of sort of, familial short stature, but I don't get a sense that there's a lot of malnutrition and stunting, at least in the communities that we go to. Very little obesity, but there's some, we do, this, and then there's this culture that, bigger is better. So it's hard to convince people that, if their kids are overweight, that, that's not necessarily a good thing. They think that's a healthy thing. But yeah, but I think that anemia is, I think it's nutritional. There's not a lot of, rice and potatoes are more affordable than meat. So that's what I think. Robbie's got his hand raised.
We have more questions. Dr. Benjamin has a question.
Yes.
Thank you so much for this really interesting talk, and thank you for all the great work that you're doing. What a great experience for the medical students. That's really awesome.
Thanks.
My question was, and I'm sorry if I missed it, I was driving during part of the presentation, so I might have missed it, but do you do any HIV or STI testing and or contraceptive management at all while you're there?
So not while we're there. No, I mean, we don't have the we don't have the facilities or the resources to do that. I mean, again, if anything that's anything that needs to be done that we can't do, we try to refer patients to the clinic. I mean, I will say that the Sachila communities, especially the ones that are farther away, they usually won't go. I was on a trip once years ago where we actually had an OBGYN from somewhere else in the Midwest who saw a lot of women and may have done some of that, but we don't. We're just not equipped to do that. So once these additions are made to the clinic, I mean, they'll have a full lab. I mean, right now they do hematocrits, they don't even have a CBC machine, anything like that needs to get sent out, to a local laboratory or the hospital in Santo Domingo. So I think once the additions are made to the clinic, I think, and I think they are hoping to add an OBGYN person to the staff there. So right now it's this general practitioner and this part-time cardiologist, and then the dentist, I believe, are the only physicians working there. There may be one or two other part-time, but they're hoping to get a gynecologist. Ravi, what was your question or comment?
Thanks. There is another question by Dr. Ravi.
Yeah. He's still there.
Ravi, you are muted.
Oh, you're muted. Yeah.
Okay, good. Okay, so very interesting. So my question about the anemia is how common was it? About proportional?
So,
children?
not very common. I would say, so most days I saw probably usually around 15 patients, so kind of like a day in the clinic here. And I would say most days I would maybe at the most have one or two patients that I actually treated for anemia. So the majority of patients that we saw, it used to be much higher, the proportion of patients with anemia that we saw. So I'd say at the most, maybe 5 to 10%. Just and again, not database, just from my impression from what I saw. And my colleagues were kind of reporting the same thing, that they really were seeing very few kids with anemia, at least this go around. So I would say we see more anemia probably in the Sachila communities than we do in Santo Domingo.
Is hookworm infestation a common problem in?
So I think it is. I mean, we don't test for specific parasites or anything like that. We just we treat the kids.
So maybe the anemia is it's a common cause of iron deficiency anemia. Now, I was interested in your Ascaris observation. There is a body of literature that suggests that prior infestation with Ascaris might decrease the incidence of autoimmune diseases. It apparently promotes innate immunity in a certain fashion. And actually some controversial treatment practices for adults with some autoimmune disease, they actually artificially induce the Ascaris infestation. And so I was wondering if you have
so is this kind of like an evolutionary advantage?
I don't know what Ascaris does, but
kind of like sickle cell and malaria.
Were you seeing a lot of lupus or ulcerative colitis and things of that nature?
No, I wasn't, and I don't think the folks that were saying, I don't see any adults there.
For the sake of time, Ravi, we need to move on. We have last question from Dr. McGrath.
Well, I just wanted to ask you about, we hear a lot about from this part of the world, Ecuador, Guatemalan people coming to the US and at the border and, you know, escaping as refugees or as, you know, under duress in a sense of, I don't know, do you encounter that there? Like, are there, you know,
No,
you know,
no, and
drug
actually,
cartel issues and things?
what kinds of issues?
Like drug cartels killing people left and right and all we hear.
Here, you know, so we, you know, we always, we get a, you know, kind of the Pablo, who's, you know, kind of the Ecuadorian person that leads us, you know, always gives a little kind of introductory, you know, when we're doing orientation, and he does talk about crime, you know, that there are some areas of Santo Domingo where there is, you know, there are drugs and there's crime, and, you know, we encourage people not to, you know, go out by themselves. We can, you know, we can go into town in groups and that kind of thing, but not, no, nothing that I've seen or that I've been aware of, or that any of the patients that I've seen have been involved with. So, you know, it probably exists, but not in the communities where I've been.
Thank you.
So,
Well,
yeah.
thanks for, you know, changing my perception also, you know, because all I know is the TV version of Ecuador.
This is this town. This is not a town you would go to as a tourist. You know, there's nothing. You know, there is nothing. Although it's interesting because one or two of the Sachula communities have tried to promote tourism. We actually, the cultural presentation that we had at the trip that I went on last month, they actually have like a little museum set up, and you go to these different stations and they talk about their different medical practices. I didn't mention they're Catholic, but they also have their own traditional beliefs, and the person that puts on these some of these exhibitions is usually a shaman, so they do have their own medical beliefs, you know, which we try to respect, you know, and that they demonstrate for us. So like that cleansing ritual and the hair dyeing.
Yeah. Well, you know, thanks again, and
Sure.
you know, really appreciate your presentation, and thank you everyone for joining us, and you all have a great day.
Thanks everyone. I'll see you in clinic. I gotta run in.
Bye.